All right, so just briefly, I'm Dr. Rimma Shaposhnikov. My office is right here in Westlake. So I was able to convince UCLA a long time ago that I don't want to drive to Westwood and you guys need care here. So we started our very first office about 8 years ago. There's now, or almost 9 years ago, so now there's about 7 GI doctors in this area, not to include Beverly Hills and Torrance, but we're covering both almost Simi Valley soon, but for now Porter Ranch, West Hills, Westlake, and Thousand Oaks, all right? So without further ado, March is the colorectal cancer month. So this is it. This is the month we tend to tell everybody as soon as they walk into our office that screening is mandatory, and I'm here to tell you why. So I know everybody's following COVID-19, and every time you hear that there's a death out there, right, everyone is panicking. Well, I think we should start panicking about colon cancer. And the reason for that is 50,000 people are expected to die this year alone. Screening could save more than half of those people. So that's the reason probably that you guys are here, and that's the reason I chose this field, to make sure that everybody comes in and we can be prevented from having colon cancer. We want to make sure that everybody gets screened and is aware of everything out there. It is the second leading cause of death and second most common cancer in women. 1 in 3 people who are diagnosed with cancer will die of it, and lifetime incidence is 4.4%. Nationwide, that translates to about 150,000 new cases a year, with about 57,000 deaths. So again, we're right behind lung cancer, but definitely above prostate and breast. All right, this is just a slide to show you that as we age, starting at age 40, colon cancer incidence increases, whether you're white, black, male, or female. And the most important part is that, again, it's preventable, which is... I'm sorry, say it again? The Hispanic people, actually similar rate. No, similar rates as white people, yes. The only group that and we'll talk about that in a little bit, is African Americans. So yes, Hispanic patients, same rates. So colon cancer is preventable. I happen to be a woman, and of course the reason I went into this field is I want to make sure that all the female patients are taken care of as much as our male counterparts. So we're diagnosed at the same rate as men, but are less likely to get screened. So let's make sure we change that. So guidelines for screening. Average age is starting at age 50. For African Americans, we start at age 45. High risk are patients who have family history of colon cancer, first degree relative, or 2 relatives that are second degree. We start them 10 years younger, or at age 40, depending on which one is younger at that, which one is sooner. People who are in good health, we probably will not stop at 75. We may continue screening them, right? As long as we consider life expectancy to be an extra 10 years. So my very first patient was 96 years old when I started my private practice, and she said, I demand a colonoscopy. And when I said, you know, you're good, you don't need it, right? Because most patients don't want it. And she said, well, my parents have lived past 100, so I expect to live past 100, and I demand a colonoscopy. We negotiated something else, but I was really excited that she wanted to get screened, right? So don't let age stop you. So who is really considered high risk? Of course, having personal history of colon cancer or even colon polyps. You're considered now high risk. Any family history, and we can talk about that as well. Personal history of inflammatory bowel disease. Of course, any hereditary colorectal cancers, such as Lynch syndrome or familial adenomatosis, FAP, multiple polyps that are found in patients, and of course personal history of getting radiation to the abdomen is also considered a risk factor. So lots of data that came out 2 years ago saying no, we must get screened sooner. A lot of young people are diagnosed with cancer and we're missing it. So yes, of course, we do agree with American College Cancer Society that young people should be screened before age 50, starting at age 45. The problem is the insurance companies have not agreed to that yet, right? So let's try to get all the people starting at age 50. And of course, on an individual basis, we do screen people who are younger than that. Right. So the reason I put this slide in is a lot of times I see younger patients, right? And they tend to, and we all have children, and they tend to minimize symptoms, right? They go, yeah, we'll go away. It's just the party. It's just something I drank, something I ate. Now a couple of weeks go by and those symptoms have persisted. So they did a survey, because let's be honest, how do young people communicate, right? It has to be on email or on their phone or a text, right? No one talks in person anymore. So looking at almost 1,200 patients, they noted that 63% of them waited almost a year, right, before visiting the doctor if they had symptoms. Almost half of them had 3 or more symptoms: rectal bleeding, fatigue, blood in the stool, pain, nausea, vomiting, bloating, flatulence, right? Symptoms that if you knew about it, right, you would tell your children, your friends, or even yourself, you probably should see the doctor sooner. Almost a quarter waited a year. 67% were misdiagnosed, or saw maybe 2 physicians or more. Some ended up seeing 4 physicians. And the reason for that, when you come in and you don't give a full story, right? You say, I have occasional rectal bleeding, it's not a big deal, I maybe traveled, I was constipated. We tend to come up with excuses and try to explain our symptoms because young people are not supposed to have cancer, right? And by the time stage 3 or 4 were diagnosed, 71% of them were pretty advanced, right? So the reason we tell you, this is not a screening test. They're already symptomatic, this is diagnostic. But I put this slide in just so you're aware that symptoms do occur, and we want to make sure that everybody is addressed. So I told you that African Americans are at high risk for colon cancer, and I told you they should get screened at 45, and I did not address Hispanic or whites because we do tend to put them in a later category of age 50. And the reason for that, we think that it's probably lack of symptom recognition more than biological difference, right? Not the great access to care that everybody deserves. So again, for now, we think that everybody is similar. So what is a screening test? Screening test is a process of detecting early cancer, right? You don't want me to tell you that it's already advanced and there's nothing I can do. I want to get it beforehand. Now, colon is a good organ. If I find a polyp, I remove a polyp, you don't have cancer, right? I'm not going to say anything bad about all the other screening tests you might have had, but if you had a mammogram, right? How many of you have a friend that maybe had a mammogram that was normal and then was diagnosed with cancer 6 months later, right? Not a perfect test. Pap smear, not a perfect test. Even PSA, and I'm pointing to you because of course you're representing all the men in the world, but PSA, right? Not a perfect test. So just keep in mind that this is a really good test. We find something, we remove it. We've now just prevented you from advancing to colon cancer. We want to take asymptomatic people, right? If you already have symptoms, your doctor, whether it's primary care or GI doctor, will make a decision if you need a colonoscopy. But at that point, we're looking for a source of your symptoms, for source of bleeding, right? Again, not a screening test. The object is to reduce cancer. I want to reduce not only the incidence, but I want to reduce that mortality. To me, 57,000 patients dying a year is crazy. That's a high number, right? And that's significantly higher than any infection that is out there in the world right now. So we want to have tests that not only detect early stages, but of course can detect high risk or precancerous lesion, and of course detection and removal of this lesion will prevent cancer. United States has achieved world's highest rate of colon cancer screening, but look at that, we're only at 60%, right? So we're missing 40% of our population that we can save. So again, pretty high numbers. And let's do it by state, because now that we're watching all the election, everyone is excited about each state. So we're doing pretty well as California. We're at 69%, right? We're better than other states. But why are we not at 100%? Why is everybody not getting a test that can prevent them from dying? So this is a pretty important test. So when you leave here, you're going to go home, and you're going to, oh, not sure what just happened. Okay, here we go. All right, sorry about the test. It may not come out. There's multiple tests. Of course, I will talk to you about the colonoscopy because that's what I enjoy doing, and it's considered the gold standard. There are other tests available, right? And if by the end of this visit, you feel like colonoscopy is not for you, be aware that there's other tests. Now, CT colonography is a virtual colonoscopy. That's the visual exam done by radiologists. So it's a CT test that can look and scan your body. Keep in mind, you have to drink the prep that you do for the colonoscopy. You're awake during the procedure, so that discomfort that you're worried about is obviously there. The radiologists read the test a little bit differently. They may not call every single lesion. They can't tell a difference between a stool sometimes, right? And of course a smaller polyp, so they don't call every little polyp. We, however, all doctors have 20/20 vision. We, however, when we do your colonoscopy, will remove anything, and of course if we think it's stool, we'll wash it right off. And not all insurances will pay for that CT colonography, so please beware. Flexible sigmoidoscopy, great tool. The problem is it only looks at a very small part, about 1/3 of your colon, right? So again, great test. We used to offer that a lot to people who are younger, right, less than 40. But at this point, if you already sign up for having a test, you might as well get the full experience, right? But some people do get the flexible sigmoidoscopy with a stool test. So let's talk about what else is available. So people always go, well, which test is better, right? I want the best. I'm paying for the best. My insurance is covering what is the best. And honestly, the best test is the one you're going to get done, right? Whatever test you choose, as long as you get it done, we're pretty darn happy. But because we're doctors and we like to quote statistics, right, they found absolutely no head-to-head difference between what test was better for each patient in preventing mortality. So all of you are probably familiar with those old stool cards, right? We would send you home with 3 of those, or a doctor would do it in the office. And we would say, okay, just make sure you're not eating beets and vitamin C. And we would give you so many things that by the time you did the test, you're like, if it's positive, you try to convince yourself that you probably ate something you weren't supposed to. And then you said, oh, but let's do another one in case your test is wrong and maybe I didn't put the stool on correctly, right? So I've heard all your excuses, as did the nation. So now we have different tests. It's called FIT. So it's a little bit better. It actually detects the cancer almost 2.5 times more than the old test. And of course, it detects also advanced adenomas, polyps that are advanced and may then turn into cancer. Positive test, only one is needed. And if you have one, you definitely need a colonoscopy because now something is bleeding, something is not normal. So if you get that test, you're now due for a procedure. Again, one test is enough. And I love my phone calls that I get saying, well, maybe it wasn't done correctly. Maybe I can do it in the morning. No, doesn't matter. One test is enough. Right here. Okay. So again, some non-invasive colorectal tests. The only reason I included this slide is the stool DNA that's now available. You guys know it as the Cologuard, right? And it comes in a beautiful white box. I'll show you the screen in just a little bit. Again, looking for precancerous lesion. Again, it's only a single stool specimen, just the FIT. There's absolutely no dietary restriction. And looks for DNA analysis and sees if you're at risk for colon cancer. So when you go online, this is available. I just put this in there as how to do your stool test, right? But all the instructions come with a package. It really is not that impressive. But once you go online, and if you have any questions, I'm more than happy to go over the FIT test. The Cologuard was approved in 2014. People were reading about it in New England Journal of Medicine and, of course, seeing all the ads. It is a multi-target stool DNA test. It detects not only the blood, that's the hemoglobin, but also the molecular, the DNA analysis of you, trying to figure out if you're at risk for colon cancer. Positive test, you need a colonoscopy. Negative test, you probably need another repeat one in 3 years, and we're still trying to figure out, although it has really good sensitivity and specificity, and is an excellent screening test, is it really perfect? And the answer is no high rate of false positive, meaning the test will come back positive, you get a colonoscopy, and it's negative, and you go, well, what do I do with that information now? Well, I don't know. I don't know either, right? So we need to figure out, does it mean you're going to get a polyp in 5 years? Are you predisposed to it? Are you really going to get it? Are we missing a polyp, right? So it kind of raises more questions than not. So be aware, we're doing more studies on this Cologuard. So a couple of limitations, right? So when you go on Facebook and everyone says, you don't need to get a colonoscopy, Cologuard is good enough. Keep in mind, if you have family history of, oh, that's a different slide, but I'll get to that in a second. If you have family history or personal history of colon polyps or cancer, that is not a good test for you. So if you're predisposed to colon cancer and the doctors think you're high risk, Cologuard will just confirm it and you've just wasted a bit of money. So no evidence on reduction of colorectal incidence or mortality because, again, it's a fairly new test. The data is still coming in. We don't know cost effectiveness of reducing mortality. Again, it's only one-time test that was studied. And what was impressive was that patients failed to complete the stool DNA as compared to that little card. So it gives you a little bit more information, but not everybody is as compliant. All right, so this is what I mentioned earlier, right? If somebody has a positive result from another screening test or at higher risk, Cologuard is not the study for you. Any questions so far? We're a small group.
What's you said they didn't complete the full test?
So remember, not everybody reads the instructions properly. They might have not finished the test. didn't submit adequate sample, right? Or took the test and really never sent it back for whatever reason. So remember, there's a survey of patients who are, the primary care doctor says, you can get a colonoscopy, you can get a stool test, you can get a Cologuard or a little card, and then they go, okay, what happens? You've asked 11,000 patients to get it, how many are actually coming back? And they do these statistical analysis. So this is one of them where FIT test was a little bit easier, smaller card, and patients were more likely to submit it.
So is it polyps? And I said, can polyps develop into the...
Yes, and we'll get to that in a second. The reason we do this is we're looking for polyps, which look like little warts, and I'll show you a slide, and they grow bigger and bigger and then become cancer. So the reason we do colonoscopy is we can remove those little polyps and prevent you and the polyps obviously from growing into cancer.
So when the polyps are removed during the colonoscopy,
Absolutely.
Would you recommend that patient to come back before?
Yes, you're taking all my slides away, but yes. Yes, yes.
What's the second one, the familial adenoma?
But, okay, adenomatous polyposis. So it's a disease where patients have more than 100 polyps. So it's something that somebody would know by age 20.
Yeah.
Okay. All right, just another reminder that when we rank the colorectal cancer screening test, we do recommend colonoscopy, and because that test, if there's no polyps, is every 10 years. If there are polyps, then your doctor will decide whether it's 3 or 5 years, maybe even sooner. And FIT, if you do the little card, it's annually, right? So you have to do that test every single year. All right, so colonoscopy, everyone is absolutely terrified of it, right? Raise your hand if you want to just wave at me so you're not on camera. How many of you had a colonoscopy? All right, you're young. I'll let you that one slide. Okay, perfect. Was it as horrible as you thought it was going to be?
The cleanup was.
The cleanup, the prep. Okay, and the rest of you, other than that?
They knocked me out, so I don't know.
Okay, so you were asleep. Perfect. So you don't need a medal for this, right? We're okay. All right. So excuses that I hear day in and day out, right? And I see quite a few patients a day. Oh, I have no family history of colon cancer. Don't you worry. I'm worried about my heart disease. I'm worried about my breast cancer. Colon does not run in my family, right? Unfortunately, that's not true, right? 57,000 patients that die, 147,000 that are diagnosed. Not everybody has family history of colon cancer. But it is important to know your family history, so make sure when you do go to the doctor's office that you've called your family, if you know, got as much information as you can, so when we do see you, we can reassess your risk, because if you have family history, then I'm seeing you every 5 years and not every 10 years. Yes?
Suggest you go back and get your grandparents' death certificates, because both of them, I had a grandparent on each side that died of colon cancer that we thought was something else.
That's an excellent tool if you have that available, absolutely. So patients go, well, I have no symptoms. Well, that's the whole point of the screening test, right? Because if you had symptoms, it would now be a diagnostic test. The prep tastes awful. Can't lie to you, but what I can tell you is instead of the 1 gallon, right, you're now drinking 1 liter. So it's about 1/4 of what you used to drink before, and you can add, talk to your regular GI doctor, but you can get stuff.
The pig tastes okay, it's not bad. Bust a lot,
We won't discuss what you all had to drink in college, so this is not bad. Okay. It's invasive procedure, right? I always feel that people go, well, my neighbor's friend who I don't know, never met, had a perforation and died, right? The honest truth is the risk of perforation is less than 1%, right? So we do worry about it, but in proper hands, right? You're not getting this done, you know, just on the side of the road. You're getting it done in a proper surgical center. There's a monitor system. We monitor your blood pressure, heart rate, O2 saturation, pain score, CO2. There's a nurse, there's a tech. There's a lot of people taking care of you for that 15 to 20 minutes. I cannot take day off work. I don't want to bother my family. Well, guess what's going to bother them more if they have to drive you to chemo, right? That's really going to upset their schedule if they have to be busy every single week and every single month taking care of you, right? So promise them lunch, promise that you will take them, but this is really important. So you can work, but this is pretty important. So do take time for your health, do take time for yourself. When people go, I'm too old, I tell them that story of my 96-year-old, so none of you are too old, right? And clearly the guidelines say between 75 to 85, we're still considering you young. So take that as a compliment, get a colonoscopy. And when somebody says, I already had one, well, let me see the results, right? Because if you had polyps, you're now at higher risk. And if you didn't have polyps, you're still due in 10 years. So it's 10 years for a screening colonoscopy if no polyps were found. So this is what a regular colon looks like. We start in the rectum, and as soon as the camera goes in, I'm looking at the screen. You're fully protected, you're modestly covered, and honestly, unless you have a tattoo of my face, I will not remember what you look like, right? From behind. So we'll make sure we look at the entire colon. You know your colonoscopy is complete if we start in the rectum and take pictures of your appendix. So even if you had an appendectomy or removal of your appendix, it looks like a cute little smiley face. If we take a picture of that, then we know that we've completed the procedure. You get those pictures immediately regardless of who's done your procedure at that time. We go back and it takes us about 6 minutes to come out. We take a really long time. It's about a minute for every 10 centimeters. We want to make sure we've seen everything, right? And we follow all the guidelines that are put in front of us. And of course in the rectum, we retroflex, meaning we look back and make sure we don't see any rectal cancers and address your hemorrhoids if they're present. We think it's a gold standard. Why? Because if I see any polyps, I remove them. I've just prevented cancer from occurring. Polyps, of course, can be missed if your prep is not perfect. So yes, it's disgusting to drink it, but if you do it properly, you only have to do it every 10 years. Colonoscopy may be incomplete, again, if the prep is not perfect. It is, of course, operator dependent, so I'm not going to tell you that every doctor is the same. So keep in mind that you've done a little research before you meet your physician. And of course, time spent in the colon, we do document how long we're in your colon because studies have shown the longer time we spend in your colon, the more polyps we find. Okay? We haven't had dinner yet, but if you look at the slide right there, you can see that we will grade you. We will tell you how good that prep worked, right? So if you follow all the instructions, you really should be in the excellent or good category. And of course, if you're not as clean as we would like it to be, we will then discuss that maybe the prep didn't work properly, or perhaps you need to come in sooner. So these are some of the pictures of the polyps, right? That one is called pedunculated. It looks like a stalk and has a little mushroom appearance. I get to play all day with different equipment, right? That's the fun part of my job, is I get to remove anything that does not belong in your colon, right? So I get to clip it, I get to biopsy it, I get to lift it. I mean, I get to play a video game while you're asleep, right? Okay. So you asked me a question, why are polyps important? And this is the most important slide. We think that a small little polyp becomes larger, and it really goes from tubular adenoma to a larger size, tubular villus, and of course, malignancy, right? So we know if we remove your polyp at an earlier stage when it's still considered benign, that we've now prevented you from having colon cancer. We know there's multiple pathways, not just this one, but this is for the sake of this program, this is a pretty important pathway. So you may get, so you may get a report from your doctor after the procedure, and they will use the word hyperplastic. Now, hyperplastic polyps, usually found in the rectum, are benign with no cancer potential. A tubular adenoma is not, it's considered benign, but a precancerous polyp, and based on its size and number, the doctor will decide whether they'll bring you back in 5 years, or if there's more than 3 in 3 years, greater than 1 centimeter, again, in 3 years. And I think I put that down here, okay? Some of the alarm signs and symptoms, I did include this slide. Again, this is not a screening slide, but please be aware that some of the things we want you to get a colonoscopy because, right? So this is not, again, a screening test, but if you had any rectal bleeding, any changes or drop in your hemoglobin or blood level, any changes in your bowel habits or bowel consistency, your stool is now narrow, all of a sudden it's looser, all of a sudden you're having constipation. If there's a major change, this is a good time to see a gastroenterologist. And of course, any iron deficiency, anemia, abdominal pain, fatigue, weight loss, any symptoms that you cannot explain, that please don't sit on these symptoms. Please come and see us sooner. All right. So colon cancer is preventable. There are multiple tests that are available. And I'm here to answer literally any question you may have about the procedure because I do think this is important. Yes, sir.
On the slide that you had about 6 polyps
Yeah.
or
So a lot of
genetic testing, what's that?
So a lot of time, 6 polyps is considered too many polyps, so we will probably we'll wait for the pathology, because not every polyp that we remove, we don't have the ability to diagnose what kind of polyp. But if it's 6 polyps, depending on their size, and of course if they're adenomas, we may consider either bringing you in sooner or even getting a genetic counselor involved so we can discuss whether you're genetically predisposed. And part of that is, we worry about your whole family, right? We want to make sure your siblings and your children are aware that you're now higher risk for colon cancer. Okay? Yeah.
Okay, so I know the Lynch syndrome, is obviously tied into that. Now, if you're BRCA2 positive, I've heard both things. Some say it is related, some say it isn't related to colon cancer.
So we are not screening more often in patients who've had breast cancer who are BRCA positive.
You're not?
Because the guidelines are not there yet. Having said that, we will look at your history and it will be more individual basis, right? Will we bring you in sooner? You may not need to, right? If you've had a recent colonoscopy, you may be due for surveillance. So
I've been going every 3 years since I'm 50. I'm 70 now.
Okay.
And that's because one time he did find adenomas polyps, and then a couple times I was clear, but he said because I had ovarian cancer, because I had breast cancer.
Right, so you've had multiple cancers.
You're coming and I just had one done and it was totally clear.
Perfect.
He says, I don't care, you're coming in 3 years.
Right. Well, and again, your situation does not apply to everybody here, but you've had family history and 2 personal cancers, so now there might be more. Right. So then, that's correct. I would be okay with that.
Oh my God.
Yes.
Can other diseases like diverticulitis, can that be a factor? Or
So no, that's a really good question. If diverticulitis is inflammation of a diverticulum, which is a pocket in your colon, right? A lot of people as they get older get thinning of the colon and these pockets start to form, right? And then they can get an infection that can present with fever, chills, and pain localized to that area. And your doctor probably says to you, come and get a colonoscopy about 6 to 8 weeks after the diagnosis. So after the inflammation has subsided, we recommend somebody to take a look at it to make sure there's no cancer nearby that is causing the inflammation. Diverticulitis alone, the inflammation alone, will not cause cancer, but malignancy or cancer can absolutely cause diverticulitis. So the other way around. All right? You look like you're about to ask me something. Yeah, no, okay. Sure.
Because my dad was diagnosed at 82 with colon cancer. He was with Kaiser, and I think he had non-Hodgkin's lymphoma at 60, and then he had a colonoscopy then, he was okay, and then at 70, I don't know, he just didn't do it. At 82, they discovered he was already 4-stage colon cancer. But they said, oh, when you get colon cancer that late, it's not related to heredity or anything.
Well, again, don't know your dad's personal history, so I cannot answer that question. I apologize. But I would say that if you have family history of colon cancer, I would presume that it's related, okay? Your highest risk is 10 years younger than your father was. So at 70, the polyps start technically forming at 60. So we start you on a pattern of checking you every 5 years, or in your case, it was sooner because you had other malignancies.
Oh, so that's another question. So I have 2 sons. One was tested, he's negative for the BRCA. The other was tested, he's positive for the BRCA. He's 40, and my dad, died of colon cancer. Should I?
Are there other family? So your dad is considered a 2nd-degree relative for your son. Right? So is there anyone else in the family? This is where the family tree is important. Is there anyone else, any nephews, cousins, anyone else in the family with malignancy related to colon cancer? Prostate is
ovarian.
Right.
But no, only one person died of the colon cancer.
And that was your father.
That was my father.
So then I think technically your son should be fine later on.
50, you think even with the BRCA?
You can even do it 45, but I think 40 might be too young. Yes.
Along those lines, my mother died of colon cancer at 90, but then we found out that both my grandmother on one side, grandfather on the other died of colon cancer. I went in, I caught it, well, it was still a polyp, but it was colorectal cancer. And so my 2 sons, I said, 40, go in, and both of them got past the insurance and maybe medical piece of it at 40 is just based on family history.
Right, that's significant family history of both 1, 2, 3, 4 relatives. Yeah,
So
that's
4
significant.
generations, or 3 generations.
Yeah, so that's significant, so that's correct. Yeah. All right, keep in mind let's keep it as general as possible, and then as soon as the video is off, I'll be more than happy to answer individual questions, just so you're not on video sharing your entire life story with UCLA. Okay? All right, so if you have any questions, please, but I have Inner Beauty and I have the video from colonoscopy to prove it, so I want to see all of you get your colonoscopy so we can make sure, and again, it is treatable, preventable, and beatable, so please get colon cancer checked. All right, thank you again for your attention and for coming. All right.
All right. So hello, everyone. My name's Natalie Manitius. I'm a registered dietitian at UCLA in the Division of Digestive Diseases, and I am one of 3. So unfortunately, we don't have a dietitian out here, but if you have specific nutrition concerns, any GI conditions, we've got Nancy in Westwood, Janelle in Santa Monica, and I will be in Century City coming soon if you want a glamorous dietitian visit. So today I'm going to talk about some facts and figures related to colorectal cancer and diet, what the research tells us as far as anti-inflammatory and pro-inflammatory foods, and then I'll talk about different strategies we can use to reduce carcinogens in our cooking. So Dr. Shaposhnikov already covered some of this, but we know that colorectal cancer is the second leading cause of cancer death in men and women combined. What's really interesting about this is 2/3 of cases worldwide are in countries with high indices of development. So there's something that's happening from a global standpoint where when individuals are living in developed societies, the burden of colorectal cancer tends to increase. So there's something about the Western diet that is playing a role here, but we don't quite know what yet. And then as we talked about, the beauty of this is that up to 60% of deaths are preventable. So we're going to talk today about nutrition and what we can do with that. So the evidence that I'll talk about today is based on a panel of the World Cancer Research Fund. They're independent researchers who come together every 10 years. They look at all the research for us and they tell us, okay, these are the things that are the most likely to increase our risk, least likely, and we'll talk about some of those today. They do not rank the severity of the risk, so they can't say with certainty, like physical activity, it changes your risk by this amount, but they will tell us what things do increase your risk, and then what is protective. So the first thing that they concluded is as far as physical activity and body fat, there's convincing evidence that this can play a role in the development of colorectal cancer. What we know about it is that excess body fat can change your whole metabolism. It can change your markers of inflammation, etc. So we know that having excess body fat can be burdensome to the body and can increase your risk of developing colorectal cancer. So one way we can go about assessing this, how many of you have heard of BMI? Yeah, so BMI, I will say, is not a perfect tool. It basically is a rough way to estimate based on your weight and your height, your risk for disease. And so, for example, if I am 5'10" and I am 140 pounds, then that would put me at a BMI of 20. And so what we're aiming for is to be in this green range. That being said, BMI does not account for lean body mass. So for example, people with really a lot of muscles, they're going to be heavier. So it's not a perfect tool, but it can give us a broad sense of your risk for developing disease. Okay, so we're going to do a fun activity where I measure my waistline for everyone. So another way we can go about assessing our risk is the waist circumference. So the way you would do that, so I brought this measurement tool, and you would take one of these, and you want to place the tape measure at the top of your hip line here. And I won't tell you the number, but I will show you how it's done. So we're going to go, and you place it here, you wrap it around, And then you're going to take 2 exhalations because you want to make sure that you're not puffing your belly out. And then that will tell you what your waist circumference is. So that will tell us where you are as far as risk. Again, it's just one way of looking at the whole picture. So we want to take this into account as far as physical activity and that sort of thing. So this in and of itself is not the only thing to assess risk, but it is a useful tool. And then finally, another way we can do this is looking at the waist to hip ratio. The figure that you see on the right here, if you see the apple, the avocado, and the pear, how often have you heard of people referred to as I'm apple-shaped, I'm pear-shaped? And what that tells us is where the body fat's distributed in the body can change your risk somewhat. So for example, having a lower waist to hip ratio will put you at a lower risk. There's some thought that if you have excess fat in the central region that is covering your organs, that can change your whole metabolism. It can be associated with more inflammation. So in general, we're trying to reduce the amount of fat that accumulates in the central area. But this, again, is just one of many tools we can look at. Okay, so moving into the nutrition side. So the panel concluded that there's convincing evidence that processed meats can cause colorectal cancer. What is it about processed meats? So part of the challenge of this is there's no uniform definition of processed meats. For example, sausages we know is one, bacon, ham, etc. So part of the challenge of the research is that not every researcher is looking at processed meats in the same way. That being said, the features about processed meats that they think can be problematic are that we tend to cook them at high temperatures. So it's thought when we cook these foods at high temperatures, they form these compounds. They're long names, heterocyclic amines and polycyclic aromatic hydrocarbons. I don't expect you to remember that. The basic premise here is that those are thought to be carcinogenic. They're also thought that they can produce colorectal cancer. So the other piece of it is that often these foods are highly preserved. They have to add something to keep the food on the shelf for longer. And what that's often called, they're nitrites or nitrates, if you've heard of that. And they add it to foods to inhibit botulism. So that's one piece of it. It makes the meat pinker, which is so weird to me. But those compounds are also thought to be potentially carcinogenic. They've shown that in animals. They haven't shown it definitively in humans, but as a whole, that's one thing we're thinking about. And then another piece is these foods contain heme iron, which is one of 2 types of iron. Animal products have heme iron, non-animal products have non-heme iron. And the basic premise is that heme iron is in high doses in these foods, and those are thought to promote tumor development. So that's part of the challenge. And the thing is that there's what's called a dose response, meaning the more you consume of these foods, the more your risk goes up. And in the research, they showed that at 50 grams, that's equivalent to 1 hot dog a day or 6 slices of bacon a day, your risk goes up by 18%. So the take home here is not to scare you away from eating these foods, but rather thinking about the frequency of consuming these foods. Are there ways that we can reduce the frequency, and how will that change our risk over time? Okay, smoking and alcohol. So again, there's convincing evidence that these can cause colorectal cancer. We know at this point that smoking is harmful. Most research has held that up, but the research showed that 2 packs a day can increase the risk by 40%. Smoking is thought to create damage to your DNA, and when they did research on patients with colorectal cancer, they found that those who smoked had a higher risk of dying from colorectal cancer, having complications, and they were less likely to respond to treatment. So smoking is not working in our favor in this case. And then with alcohol, what is interesting is that the association is with over 28 grams of alcohol a day. That comes out to 2 drinks. So it's really not that much, but again, it's the question of frequency. If you're having 2 drinks every day, that can be problematic. And the reason for that is that your alcohol is converted to this compound called acetaldehyde. That's toxic to the cells of your colon. So really, alcohol in small amounts is okay, but once we increase it, it becomes problematic. So again, back to moderation. That's my job, is telling people to live in moderation. Okay. So with red meat, what's tricky about red meat is that a lot of the research for red meat, processed meat, really goes hand in hand. So in a lot of research, they didn't parse it out. And there's so many compounds in red meat that it's really tricky to parse this out. But we know that there's probable evidence at this point that it increases the risk, and for a lot of the same reasons as processed meat. So again, the high temperature cooking that comes with consumption of red meat is really thought to create these compounds that can be cancer causing. And then heme iron, again, is a component in the red meat that we're thinking might be problematic. So what this really comes down to, and I think one thing that the research hasn't looked at yet, is the quality of the meat. So meat that is grass-fed versus conventional has different properties. We know that frequency matters a lot. So if you're consuming red meat 3 times a day, that's really going to change your risk than if you have it once a day, or even less. Okay, so what's the good news? The good news is all of these foods are protective, and they recently added nuts to this list. So that's exciting. There was a 2018 study where they took about 100 patients with stage 3 colon cancer. They gave them what's called a food frequency questionnaire. So they didn't change anything about their lifestyle. They just asked, what are you eating? How often are you eating it? And what they found was that after 6.5 years of follow-up, those who had more than 2 servings per week had a significantly increased chance of survival. So that's exciting. And they found that the benefit was from specifically tree nut intake. So these are all foods that we'll talk about, but just know that these foods are on your side. Okay, so the panel concluded that there is probable evidence that fruits and vegetables are protective. What we know about fruits and vegetables, there's no research study to date telling us that fruits and vegetables are harmful. My job would not exist if people ate enough fruits and vegetables. But vegetables and fruits have this perfect package of all these nutrients, fiber, vitamin C and vitamin E are antioxidants. Zinc that's in fruits and vegetables is good for your intestinal cells. So there are a lot of components in fruits and vegetables, and from a diversity of fruits and vegetables that will overall support your body in ways that has not been captured completely. But we know the more vegetables, the better. Okay, now moving into whole grains. So they concluded there was probable evidence for whole grains being protective. And so when we talk about a whole grain, if you look at this image here, we're referring to the whole grain where the bran, the outer layer, is intact. So it's the difference between white rice versus brown rice. And the reason we care about whole grains so much is whole grains are really high in fiber, and fiber makes the colon happy. So fiber helps to keep your stool moving, which is really important. That's part of the body's detoxification process. We also know that fiber produces what are called short-chain fatty acids, which are basically food for the gut microbes. And they're also food for your intestinal cells, so that's really important. So grains, they have all these amazing effects in the colon, but then they also have all these nutrients that are really valuable. And so again, this comes back to the whole grain. So the closer it is to the whole plant product, the better off we are. Okay, moving on to dairy. So we lumped in dairy and calcium because the research it did lump them together. And they found that there's probable evidence that dairy is protective. And the reason for that is they don't know yet what piece of the dairy is having the benefit. We think that calcium might be part of that. We know that about 200 to 1,000 milligrams of calcium a day is protective. So Americans get most of their calcium from dairy. One way you can go about doing that is, say you're having like a cup of yogurt, calcium, they're required to list how much calcium is in there. So you can look and it'll show what percentage of your daily value you're getting, and that will tell you how much calcium you're getting. But we know that there's what's called a dose response. So the more you consume of dairy, the lower your risk. And they looked at individual components. They looked at milk, they looked at cheese. Unfortunately, cheese did not have as significant of an association, so I'm not out here telling you to eat a ton of cheese. And then what they're also curious about is that, is it the calcium that's the active component, or is it the whole dairy product itself? And what they found was that supplemental calcium did not have the same effect. It's really something about the whole dairy product that has these bacteria that can be good for your colon microbes. It has vitamin D, et cetera. So we're really trying to think of like the whole food product as being the protective piece. Okay, now vitamin C. So how many of you have taken vitamin C when you're sick? Anyone? Yeah.
What was the question? How many?
How many of you have taken vitamin C when you're sick? Yeah. So this is interesting because there's limited evidence for it. Part of the premise of this is that they found that individuals who have cancer they're holding on to more vitamin C than an average healthy person. We're not really sure why. There are even centers that will do like vitamin C infusions, and I don't know what benefit that produces, but vitamin C, we advocate for it again in the whole food form. So they found that at 40 milligrams a day, that's protective. For context, one orange will give you 100 milligrams a day. So again, back to your fruits and vegetables. And these are all fruits and vegetables that are high in vitamin C, so your citrus will be high, peppers, kiwi, etc. Okay. So fish. Fish is limited and suggestive at this point. The studies that they've looked at are mostly the Osaki cohort study, which is a population in Japan, and they consume a lot of fish, and they have a 40% decreased risk. Part of what makes nutrition research so difficult is it's so hard to take people, put them in a lab, feed them a certain food for a long period of time, and then measure the effects. No one wants to do that, and it's really expensive. So a lot of the research we have is what's called observational. So seeing, okay, you live in this population, this is your risk of disease, is there something about your diet and lifestyle? So that's what they have based this off of for fish. And they don't know, again, like, is it a question of frequency, the type of fish, the types of how much omega-3 is in the fish. But the prevailing thought with fish is that different types of fish have different nutritional profiles. We really like to focus on the omega-3s. And the long and story short of omega-3s is that omega-3s are essential in our diet, and you can get them from fish. And when we have too many grain-based products, then that competes for the absorption with omega-3s. So, and it's thought that omega-3s are anti-inflammatory. So basically, omega-3s are anti-inflammatory. There's some thought that that could be helpful in colorectal cancer, but at this point, we only have limited evidence. Okay, now vitamin D. So this is somewhat similar to the calcium slide, but so they were wondering in the research, is there something at stake here with vitamin D? And we're finding with more and more disease states that low vitamin D, we don't know if that's like what leads up to the disease or if that's a consequence of the disease. But we do know that if you're deficient, you're at increased risk of colorectal cancer. So they studied about 5,700 cases of individuals with colorectal cancer, and they found that for those who were deficient, they had a 31% increased risk. So they found that for those who were having enough vitamin D in their diet, they had lower risk. If they were getting supplemental vitamin D, they were at lower risk. But we don't know yet if you have too much vitamin D circulating in your body, what effect that has. I will say vitamin D is highly variable, so we get vitamin D from food. We also create vitamin D, which is one of the coolest things to me. So when we talk about seasonality and sun exposure, your skin converts sunlight into vitamin D that your body then uses. But we think of where you are relative to the equator affects your vitamin D status, the time of the year. So we're right now in vitamin D winter, even though we live in California. But in general, we want to be advocating for sufficient levels of vitamin D.
What are UVB mushrooms?
Ultraviolet, I don't know what the B stands for, but that's the way that they treat mushrooms, where they expose them to light, and that increases the... Yeah. I actually think that the majority of mushrooms have some degree of this treatment.
Okay.
Yeah.
Question.
Mm-hmm.
Vitamin D, is it fat soluble or water soluble?
It's fat soluble.
Okay, so you have to be careful how much then. Too much, too bad.
Yeah, so, yeah, and from what I've seen, patients who are taking vitamin D and who have really high levels are taking an insane amount of vitamin D, like 50,000 IUs for long periods of time. So the question was if it's fat soluble. With fat soluble vitamins, we have to be a little more careful because the body holds on to them more easily, so you're at increased risk of toxicity. That being said, most people are deficient in vitamin D. But I will say, as a general statement, do not supplement blindly. You can create harm with too much supplementation, so that's my one.
You can have the D3 levels tested, right?
Yes.
I do that with me.
Yes. Yeah.
So make sure you're not taking too much and too high.
Yes, and that's the perfect way to do it, is look at the diet overall and then test, and then if you're deficient, then we'll address it. But I will say, by and large, a lot of people get supplement happy, and they just want to take things and think it's okay, so yeah. Okay, so this will give you a sense of what we're thinking of when we talk about pro versus anti-inflammatory diets. Pro-inflammatory diets are really the Western diet. We also call it the SAD, which is the standard American diet. But it's really, this kind of meal exemplifies what we're talking about as being pro-inflammatory. It's heavy in fat, it's heavy in fried foods, et cetera. And the beauty of this is that we have a lot of stake in what we eat every day. You make that decision at least 3 times a day, so that there are ways that we can increase our fruits and vegetables and change up our protein sources so it's not all red meat and that sort of thing. Okay, so I probably scared you all with some of the red meat conversation. And the good news is that there are strategies to reduce the risk from these foods. So I always get the question at grills, like, should we not be grilling our foods? Is that harmful? And the biggest takeaway from that is that we know that if you're having grilled foods every day, that of course can increase your risk, but we have strategies to work with that. So for example, these harmful compounds, they increase the longer you cook the food. So there's a tipping point where you want the food to be cooked well enough so that you don't get sick from the food, but then if you go too far, you're increasing the production of these carcinogenic chemicals. So some strategies that we can use are, for example, if you're grilling a burger, can you flip it over more often and not let it just sit there and be exposed and create these chemicals? We can also pre-cook things, so it's not as enticing, but you could microwave something initially, so you're reducing some of the time that it's exposed. And we would want to avoid things that are really heavily charred, because that can also produce these compounds. And just keep it turning over is my best recommendation for you, and then if we can consume it less, we're better off.
Now, you're just referring to all the red meats, or chicken
Yes.
also, or just for red meat?
Yeah, so red meats in general will produce more of these because they're higher in that heme iron. Chicken will produce some of it, but to a lesser effect. So if you think of like the hierarchy, the red meats are the highest risk, and then the poultry is less so, fish is less so, et cetera.
So grilling fish, is that not good for fish?
That's a great way to increase your intake, and it produces less of those problematic compounds. But there are other ways to produce fish that, like if you bake fish, for example, that will produce less of that. So as far as how to go about implementing all of this, so one thing that we advocate for is, can we change the types of proteins we're consuming? So a lot of my patients, I'll see that they'll come in and I'll ask, what did you have for dinner? Well, I had steak, I had this, and the protein is always what shows up first. It's like I had chicken and then I had this. So what if we inverted that and we think, how do we get the vegetables to show up first and then the protein later? And the beauty of this is that protein can come from many sources. It doesn't have to be meat. It can be legumes, it can be fruit, or it can be nuts and fish. So really trying to think about, could you do a meatless Monday, where one day a week you just don't have meat, and see how that goes. We could try to do meat again as the treat rather than the main event, so rethinking in that way. And then one of the mainstays of this and a healthy diet in general is diversity. So instead of eating refined grain every day, can we try new grains? Have you tried farro? Have you tried buckwheat? No one ever eats buckwheat. I don't know why. It's really good, but yeah. And then one thing that we like to do is thinking about, can we eat the rainbow? And a part of that is because every different color fruit and vegetable has totally different nutrient profiles. So that's one way to think about, okay, at this meal, how colorful can I make this meal? And that's one way to reduce your risk. So as far as what this actually looks like, this is an example if you're eating on campus. So I wish I had a version of like how you can swap things, but the idea is like, say you had bacon and toast for breakfast, could you upgrade that to like a whole wheat toast instead of the bacon? Could we do something like turkey instead? So the overall goal of this and how we tend to treat nutrition is the biggest benefit happens slowly over time. So people who overhaul their diet overnight, a lot of them get really fatigued with it. And so what we're aiming for is, can you change one meal a week or even a day? Start from there, but make it consistent and make it last. And with that, that concludes my presentation, and I will take any questions. So I'll go back to this.
What do you think of substituting like duck eggs instead of chicken eggs?
Duck eggs instead of chicken eggs. You know, they haven't looked at those.
Duck eggs. I don't know.
Yeah, they are much bigger, aren't they?
They are bigger.
Yeah.
What do you call it? It's more yellow, thick yellow,
Mm-hmm.
center of the egg.
Yeah, I guess.
And they're more expensive too.
Yeah, they are more expensive. I think the main thing that I would wonder is how does the saturated fat differ between them? Because that's the one thing we think about with eggs, is that, because you know how one day they were like, eggs are bad, and now it's like, eat all the eggs, and they keep going back and forth. But the thought is that it's not the cholesterol in the eggs, but rather the saturated fat. And so, and then there are individuals who are more sensitive to saturated fat in foods. So I don't know head to head how that compares for duck eggs to chicken eggs. I would say it's like a lateral move, but eggs are perfectly fine in moderation. So.
Yeah, my oncologist actually told me, I asked him about eggs, and he said, eat the whole egg, the yolks have a lot of nutrients that your body needs, and eat the whole egg, not just the egg white.
Yeah, so we typically swap out to egg whites for individuals who have high cholesterol. Their bodies just naturally produce more because of other things going on. So in those cases, we might advocate for it, but I think the egg is like a perfect food. And so, but we shouldn't be having eggs all the time every day. It's really about the pattern, so. Yeah.
Go ahead. So is there evidence that probiotics, like a yogurt or other fermented foods,
Yeah, that's a good question. So they didn't look at probiotic containing dairy. That being said, that we know that overall, any GI disorder, there's typically some element of what they call dysbiosis. Do you want to chime in on this?
So yes, probiotics have been studied in very specific diseases. For example, inflammatory bowel disease, traveler's diarrhea, some of the allergies that children may have. Activia yogurt has lactobacillus, so that has been studied, as has a Lyme, which is bifidus. So some of the things that I would talk to your personal doctor to try to address, because it is more individualized than go to Costco, get whatever is cheaper and see how it works for you. It may not work perfectly for every single person. But probiotics have been studied for colon health. They do not reduce colon cancer. Oh, okay. All right. For now, it's not a magic pill.
Yeah. Questions?
So if you can't drink milk, if you drink nut milk, that's a fortified milk.
Yes.
Is that like taking a calcium pill in a liquid form, or is that considered a food? Calcium?
Yeah. Well, sure, yeah. The question was with calcium, if you can't consume dairy and you have like a nut milk, those are typically fortified with calcium. So would that be the equivalent of like a dairy-based source? I think as far as the overall profile is, it is different than like a milk. What's interesting about a lot of what we know about nutrition is that we get the most benefit from the whole product. So we don't always know, like if you take a lot of vitamin C, for example, too much is harmful to the kidneys. Like you can get a more moderate amount through food. That being said, so we don't know exactly how it's different and how it's adjusted in the body, but we do know that if you can't consume dairy, that's a really great source of getting it, because it's really hard to get enough calcium without dairy. So
it's better to drink the nut milk or better to swallow the pill?
I would, whichever one you can do on the regular, so you're getting the calcium regularly, I would say so. And there are plant sources too, like tofu is higher in calcium. Some of your leafy greens have calcium, so, but.
Check the blood work for calcium, so if you're getting too much, that will show up in blood work.
So blood work is not the best indicator for calcium. Yes, yeah, yeah.
Broccoli has some calcium.
It does, yeah. It's a small amount. Dairy is really the most significant source, but yeah, leafy greens and broccoli for sure. Yeah.
Is there anything that we shouldn't eat too much, like an overkill food?
I would say red meat and like fatty fried foods.
Healthy.
The good food.
Oh.
Like not too much broccoli or not too much.
It's really hard to overdo it on that kind of food. At worst, most people might have diarrhea if they're having too much fiber at once as your body adjusts, but your body really does adjust. That's what's so great about it. So yeah, I think it's easier to overdo things when you're supplementing, because your body processes things totally differently. So.
What do you think about organic fruits, vegetables versus regular? Someone told me that the organic may be higher in some of the nutrients.
Yeah.
If that's true or not.
So the question was, what do I think about organic and how that compares nutrient-wise? So there's been some conflicting research on this, and there's some thought that with organic foods, again, there's no pesticide residue, so that's like the main reason a lot of people consume it. There is some thought that by not having pesticides sprayed on the plant, then if you think about the plant has to like fend off disease, it has to activate these kinds of different nutrients within the plant, and that potentially there might be more antioxidants in the organic versions. But they haven't held that up yet in research. But I would say for environmental reasons, if you can afford it, there's certain foods that have a lower residue of pesticides. Yeah. So a good reference for that is Environmental Working Group is a nonprofit, and they come out with a Dirty Dozen list. So if you're wondering what to prioritize as organic, those 12 foods have the highest pesticide residue, and those would be the ones to go with organic if you'd like. And Clean 15 have the lowest residue. Yeah.
Is there any difference in diet between for the colon versus diverticulitis?
So it's interesting. The data is actually conflicting for both diverticulitis, because we used to say if you had an outbreak or an inflammation of diverticulitis to avoid seeds and nuts, I would say, just for our analyst term, everything in moderation, right? And the reason I say that is there are a lot of studies where high fiber caused diverticulitis, low fiber caused diverticulitis. So I would say if you've had an attack of diverticulitis, chew carefully, avoid constipation, and again, everything in moderation. But we would prefer if you did not eat too many seeds, popcorn, and nuts. Guys, thank you so much for coming. We really appreciate everything you're doing for us by listening to us. If you can do us one more favor, we really do read all the surveys that are on your chairs, and we take every recommendation you make and put it to good use. So please help us out. And they're anonymous, so they go straight to
discharge, we won't look at it. So thank you again. If you have any other questions, I'll be around for a few more minutes as well,
Yeah.
Natalie, and then we'll run to our families.
Thank you all, please, for another round.